Hi, everyone. Thank you so much for selecting me for this award and for inviting me to present on my research. This represents a collaboration with co-authors from Dalhousie, where I'm a subspecialty resident in general internal medicine and in the clinician investigator program, and from University College London, where I'm in my second year of a PhD in epidemiology and public health, and from the University of New South Wales, Sydney, where I'm a visiting fellow at the National Drug and Alcohol Research Centre. And I'm happy to let you know, since I initially presented this work at the Department of Medicine Research Day, it's just been accepted for publication in PLOS Medicine, so hopefully be available online any day now. I want to acknowledge I live and work in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We are all treaty people, and I hold funding from university and non-governmental organizations, but I have no relationships with industry. Injection drug use associated bacterial and fungal infections are an increasingly common cause of pain, disability, and death among people who inject drugs. And treatment in hospitals and health systems has tended to focus on antimicrobial therapy or surgery without addressing underlying substance use needs. For example, there have been a couple of studies looking at rates of access to medication treatment for opioid use disorder after people have been hospitalized with these infections. And a couple of studies found 6% within 30 days and 24% within 3 months after hospital discharge. So, suggesting very low rates of treating the underlying opioid use disorder. After people have had one of these injecting-related infections, the use of opiate agonist treatments, which are methadone or buprenorphine, reduce mortality, and there's good reason to think that they might reduce recurrence of these infections as well. OAT are once-a-day medications that cover people's withdrawal symptoms. They allow them to inject less frequently or avoid injecting. They reduce reliance on illegal drug markets and associated criminalization and violence. And they enable people to better engage in healthcare and to get superficial infections treated before they become severe. Evidence to date on OAT in this setting has been limited. There's been a couple of studies with small sample sizes and wide non-specific effect estimates. And the peculiar regulations around methadone in the United States mean it's not included in insurance databases where people might be able to study this. But these patients are a major priority for my clinical interests and my clinical and research work. And so better understanding the role of OAT in this setting might help inform treatment planning for these infections. So our research question was, among a cohort of people with opioid use disorder who have been hospitalized with injecting-related bacterial or fungal infections, is the use of OAT associated with decreased risks of death and of rehospitalization with injecting-related infections? The data for this study come from the Opiate Agonist Treatment Safety Study, which is a population-wide linked administrative cohort from New South Wales, Australia. And relatively unique for this type of data, it includes reliable data on methadone and buprenorphine. And this is because all people accessing OAT in New South Wales, Australia, need to have a permit and be registered with the government for each date that they're receiving these medications. And this study includes anyone who's accessed treatment even once between 2001 and 2018 in New South Wales. And the OAT permits and their dates of medications received are linked to hospital, incarceration, and mortality records. And while it only includes people who have ever accessed treatment, it is estimated to include more than 3/4 of people who inject opioids in New South Wales. For our analysis, the participants all had opioid use disorder, and that's the case for everyone in the OAT study. And we selected people who had an emergency or unplanned hospitalization with an injecting-related infection. You can see the groupings of the infections here, and we identified these by ICD diagnosis codes. Participants had to survive their hospitalization and be discharged to the community, and this was so that they would be eligible to potentially be exposed to OAT. We had two main outcomes of interest that we assessed in separate analyses. The first was all-cause death, and the second was a participant's first rehospitalization with an injecting-related bacterial or fungal infection. So we wanted to see if this would reduce recurrence, if OAT would reduce recurrence and help keep people out of hospital. Our primary exposure was OAT use, including methadone or buprenorphine. After surviving this initial hospitalization, and we defined it as time varying by day of receipt. This means that each participant's follow-up time was divided up into treated and untreated time periods, and all of these time periods contributed to follow-up in our analyses. We selected out covariates for our multivariable regression models that include from data that was available in the administrative linkage. This included participant characteristics like age, sex, gender, Aboriginal or Torres Strait Islander status, prior hospitalizations from poisoning or toxicity from drugs and alcohol as an indicator of addiction severity, prior incarceration as an indicator of social vulnerability, and some characteristics of the index hospitalization, like calendar year looking at period effects and premature discharges against medical advice. We conducted our analysis in 2 stages. First, we generated Kaplan-Meier curves to assess the relationship between OAT use and the cumulative hazard of each of these outcomes. We used a model to extend Kaplan-Meier curves for time-varying exposures, where we plotted treated time periods against untreated time periods. And this can be interpreted as the estimated survival for patients who did not change their OAT status during follow-up. We then went on to generate Cox proportional hazard models to estimate associations between OAT and each outcome. And this produced adjusted hazard ratios with 95% confidence intervals. Overall, we had just under 9,000 participants. They were typically in their late 30s, just over a third were women. Relatively few had prior hospitalizations for drugs or alcohol, but 43% had been incarcerated in the past. In terms of what brought people into hospital, just under 80% had diagnostic codes for skin and soft tissue infections. Fewer had other types of infections, but because of the large sample size, we still had several hundred with endocarditis, osteomyelitis, septic arthritis, and 14% were discharged against medical advice. For our mortality outcome analysis, 17% of participants died over a median 6.5 years of follow-up. You could see the Kaplan-Meier survival curves diverge nearly immediately and continue to stay wide apart throughout the follow-up period. And we did find OAT was associated with a reduced hazard of all-cause death with an adjusted hazard ratio of 0.63. This large effect estimate on the benefit of all-cause mortality is consistent with the effect seen of OAT in almost every setting. It seriously reduces the risk of death of people who inject. For the rehospitalization outcome analysis, this was really our novel contribution. 41% of participants were rehospitalized over a median of 3.4 years follow-up. You could see here the survival curves diverge earlier on, and the 95% confidence intervals are separate. Later on, during follow-up period, they start to overlap and continue to do so. This was consistent with our Cox proportional hazards model, which found that OAT was associated with reduced hazard of rehospitalization with injecting-related infections with a much more modest effect estimate, adjusted hazard ratio of 0.89. Based on the shapes of these Kaplan-Meier curves, we went on to do a supplementary analysis that consisted of period-specific hazard ratios. So each row here is the fully adjusted hazard ratio at a different time interval in follow-up. For the mortality outcome in this first column here, you could see the hazard ratios were lower, or the estimated effect size was larger earlier on after hospital discharge, but continued to be quite large throughout follow-up period. With the rehospitalization outcome, once again, the effect estimate was larger, meaning that the adjusted hazard ratio was smaller, below 1, sooner on after hospital discharge. And out by years 4 to 6 after hospital discharge, it was no longer statistically significant for preventing rehospitalizations. So we interpret this as meaning that it's important for people to get on treatment as soon as possible after their hospitalization. We recognize some strengths and limitations of this study. We used a well-established administrative cohort that's been published multiple times, really well described and understood. The largest sample size for a study looking at injecting-related infections. We had a well-defined exposure where we had each date of medication receipt and population-wide data for the whole state of New South Wales. Some really important limitations were that because we used administrative cohort data, we had no information on injecting practices, housing status, or stimulant use that might not benefit from opioid use disorder treatment. And in Australia, their risk environment for these infections is different than in Canada. The United States, they still have powder heroin, which is more soluble and perhaps lower risk for these infections overall. And they do have good widespread OAT access on a public insurance scheme. So overall, we interpret this as saying that among people with opioid use disorder hospitalized with injecting-related bacterial and fungal infections, use of OAT is associated with decreased risks of death and infection-related rehospitalizations. Unfortunately, rates of death and rehospitalization remained high for this young cohort of patients, even among those exposed to OAT. And the absolute benefit of OAT on rehospitalization risk was modest. In terms of implications, we think this means clinicians, hospitals, and health systems should offer OAT as part of multi-component treatment planning for patients with bacterial or fungal infections from injection opioid use. I just want to acknowledge all the co-authors and collaborators and funders as well. And thanks once again.